Hello everyone, and welcome to this hopefully short and succinct video to review the new process for immune globulin within Manitoba. So what we're going to discuss today, I'm going to go through why we need to make a process change with respect to how we order and review and approve immune globulin, intravenous immune globulin and subcutaneous immune globulin. Then we'll review what the process is, the resources that have been developed, the documents that will be required, and once we've gone through that, we'll review the important notes of the new process, and we'll hopefully tie it all together with some case studies. The primary intent of this new process with respect to immune globulin is to ensure that we're providing immune globulin for the right diagnosis, that it's been given at the right dose, and for the right duration. And as we speak a little bit more to it in the next slide, you'll understand why we've come up with a simple screenshot of this for folks to kind of keep this in mind with respect to ordering immune globulin. So some background for those of you who probably haven't heard it yet. Manitoba has been identified as one of the highest users per capita of immune globulin across Canada. So you see here that we have one of the highest uses of intravenous immune globulin, IVIG, as well as subcutaneous immune globulin, SCIG. Even compared to Ontario, we're about 30 to 40% higher across the board. So this current usage of immune globulin is unsustainable, and we're seeing about 10% growth year on year, and it's just not going to provide us with the product for the patients who are going to require it. In addition, thanks in part to COVID, we are seeing an impending shortage of immune globulin, and Manitoba Health has identified this as a targeted practice improvement, so it is imperative that we look at our utilization for immune globulin. It's not a finite resource, and we have to be mindful of our utilization of this product to ensure that the patients who require immune globulin will still have access to it. This has been a very collaborative project. We've had people from Choosing Wisely. It's a collaboration between Choosing Wisely Manitoba with Christine Peters and Haley Barker, in addition to Shared Health with Dr. Masuka and Dr. Panopalam and myself. I'm Darcy Heron, the technical director. In addition to Blood Management Services, or Best Blood Manitoba, with Tracy Voth and Jim Diacu. So we've used Choosing Wisely, Best Blood Manitoba, and Shared Health have worked together to devise and develop this project with respect to immune globulin utilization. You may remember a few years ago, we started a project to look at the assessment for immune globulin, where we introduced both annual and 6-month follow-up forms. We have seen some improvement with utilization, but it hasn't arrested the use of immune globulin. If anything, it's at least provided some exposure to clinicians that this is something that we are looking at. So in order to improve upon that, we are going to incorporate 2 new resources. One of them is this criteria for the clinical use of immune globulin. It's also known as the Tri-Jurisdictional or the Prairie Guidelines. This document was devised from specialists across Alberta, Saskatchewan, and Manitoba, where they looked at all of the clinical indications for the use of immune globulin. And based on that, they looked at whether the indications, they outlined indications where immune globulin is effective, where the use of immune globulin is ambiguous, or where there is no proven effect with respect to using immune globulin. So we're going to use these guidelines when we look at every indication that a physician is requesting immune globulin for. In addition to that, we are going to look at the ideal body weight and use an online dosing calculator. So by having a better idea of whether the indication is appropriate and including the patient's height and weight to look at their ideal body weight for dosing, we're hoping that this will really bring our usage in line. Our current process right now, just as a quick review, as I'm sure you're all well aware, the clinician or the ordering physician requests the product, and that goes to the clinical unit or the unit clerk who will complete our current request for release. The request is then typically sent the day prior that the product is required. The blood bank will review it, and we'll look in eTrace line to see if an initial or our current follow-up form is required, and then if the physician ordering the product is on our prescriber list. That was another gateway that we had in the old process. And then we will go ahead and issue the product. As I mentioned, it hasn't been very successful in arresting our growth. So with the new process, we've had to incorporate some new documents. For the blood bank, that will include reviewing the request for release. We've got a new job aid for reviewing all of our requests for immune globulin. We will also incorporate a letter that the blood bank will send to the ordering area if information is missing from a prescriber document. And if there's a dose change, we have a label that will be sent along with the ROT. And the other document we're asking for is a prescriber document, and this will come from the ordering physician. It could also be considered their clinic note or their progress report. So we've updated the request for release of blood components and product. We've made it fillable, and we will be archiving the current IVIG SCIG physician initial treatment form and the follow-up form, and we will not be retaining the approved prescriber list. In addition to the process change, we've updated a myriad of SOPs, and I've just compiled them for you here as a summary. All of the resources can be found primarily online. So for the blood banks in particular, the criteria for the clinical use of immune globulin, the Prairie guidelines, the large PDF document, we have uploaded it to the L drive for all eTraceline sites. In addition, the non-eTraceline sites could access the PDF and affix it to your desktop on the computer. And it is available, all of our documents are available on Best Blood Manitoba. In addition, the ideal body weight and dose calculator can be found on Best Blood Manitoba. So I'll just click on these links right now and show you. So if we go to Best Blood Manitoba, it takes us directly here to the Prairie guideline for the clinical use of immune globulin. So again, this was compiled in 2018 and issued, and it has organized or categorized all of the indication that immune globulin can be used for into either green, yellow, or red categories. If it's green, that means there is evidence supporting the use of immune globulin as treatment. If it's yellow, it means it's a bit ambiguous. And if it's red, that means there is no evidence showing that using immune globulin is effective in treatment. The other resource that we're using for this process is the dose calculator. And again, this can be found on Best Blood Manitoba. So here we have the ideal body weight calculator for IVIG dosing. We will also be using this for subcutaneous dosing. You just enter the height of the patient in centimeters or inches, their weight in kilograms or pounds, and whether they're male or female, in addition to the dose per of gram per kilogram, which can go up to 2 grams here. The dosing weight will calculate, and then the IVIG dose based on the information that you've provided off of the request for release form. And then we round down. So we round down to the nearest increment of 5 in Manitoba. So the new label that we're going to use is, it's been given a document ID number. It's F1608039. It is available in Intellex. So as we go through, I'll just review the documents first, and then we'll get into the actual process. This label will be used by the eTraceline site and will be provided along with the ROT when the calculated dose is lower than the dose requested by the ordering physician. We will enter in the dose that was issued by the blood bank, the date of issue, and the initials of the technologist. This is an example of the prescriber document, which should be coming from the physician or the clinical area. The transfusion medicine physicians on call will be reviewing these prescriber documents, and there's criteria here on the right that they're going to be looking for to ensure that this is contained within the document, and it gives them enough information to review the assessment and whether or not to approve the request or deny the request. If they find that when reviewing the prescriber document, information has been missing, such as information pertinent to assessing the patient, such as alternative therapies have been used, if there's any adverse events, then the transfusion medicine physician will reach out to the blood bank and request that the blood bank send this letter, which we've also given a document ID, that this be sent to the clinical unit or directly to the physician. And it is going to be a form letter. You can just fill in the patient's name and the date of birth, and then just select the category that the physician has indicated is missing. And at the bottom, you can select which transfusion medicine physician on call is the one that is doing the review. So again, in the new process, we've got new forms to summarize. We've got the request for release of blood components. So this is our current form, but it has been updated. There is an SAP number for ordering, and it is a global ordering number. So anyone outside of the WRHA can order this either through the print shop and reference the SAP number, or they can find it online. So we'll have a look at the request form and see what's changed on it. So we have made it fillable. On the left-hand side, we've got the ordering physician information. We need to have the full first and last name of the ordering physician, the location of the patient, and the facility that is requesting the information. And we need a 10-digit phone number in case the TM physician needs to get in touch with either the clinical unit or the physician. So it's very important that we have very good, robust ordering information or contact information, so the TM physician can get in touch and get the information that they need. We've also required, as well as the clinical indicator, home delivery instructions from our home products, our home program patients. We have the blood components listed at the top, and then this area here for the IVIG SCIG has been expanded. We have again included the dose calculator link here, as well as the information that's needed to do the dose calculating, the patient's height, their actual weight, and the date that it was measured, and their sex. For IVIG and SCIG, we've got the dose and capture the grams per kilogram or how the patient is to be dosed. And then at the very bottom here is what the clinic is actually asking for to be released for that day for the treatment. We've also identified that a prescriber document must be attached for all initial or one-time requests for immune globulin, and again at 6 months for ongoing therapy patients. So what we'll do now is we'll go through the job aid and we'll go through the actual process for ordering immune globulin. This is a new job aid, and we appreciate that there will be changes, so we look forward to any feedback that you can provide. We've divided it into inpatients and outpatients. They're primarily the same with respect to the documentation that's required. It's just the time frame with reaching out to the TM physicians. For inpatients, we do consider them to be reviewed and approved as soon as possible. So when we receive the request for release in the blood bank, it should be accompanied by a prescriber document. So all blood banks, when they receive the request, are going to do their clerical check and ensure that a prescriber document accompanies the request for release if it is the initial or one-time request. So if you have, for example, an inpatient who is going to be in the hospital for 5 days and a request has come where they're going to get immune globulin over 3 days, you only have to submit the initial request for release with the prescriber document. You do not need to then submit that to the TM physician for the second or third day. We ask that you then do a dose review, and we've got the link here for the dosage calculator on Best Blood Manitoba. We do not need to use the dosage calculator for patients who are less than 18 years of age. And if there's no entry listed on the grams per kilogram on the request form, you can look in the Prairie guidelines. And also on page 4 of this job aid, I can show you where we do have this information summarized for any indications that would be considered green under the Prairie Guidelines. We always, as I mentioned prior, will round down to the nearest increment of 5. When there is a difference between the requested and the calculated dose, we will always issue the lower dose. So even if you see where the requested dose is lower than the calculated dose, then we will just go ahead and issue the requested dose. But in a situation where the calculated dose is lower than the requested dose, that's when we will utilize that label, and we will send that label along with the request for release to the clinical unit. It is then up to the clinical unit to implement that into their process to notify the physician that there was a change in the dose. So with our inpatients, if the clinical indication is green, then you're going to go ahead and just issue as per normal. If the clinical indication is not green, if it happens to be yellow or red, then what we're going to request is that you scan the request form along with the prescriber document and send it to the Bloody Docs email. In the email, under the subject line, if you can say that it's an inpatient, it's an IVIG request, the date, the time, and the site that you're sending it from. In addition, because it is an inpatient, if you could then page the TM physician on service, and they will then know to look at the request as soon as possible. If the request is denied, the TM physician will notify the blood bank, who will then complete the TM consult form, write that the order was canceled, and then scan and send both the TM consult form, the request for release, and the prescriber document to the TM office. And we will retain these and keep track when a request has been denied. If the request has been approved, then we just follow the normal issuing processes. For the eTraceline site, the eTraceline site will be the one that is responsible for providing the label if a lower dose is issued as opposed to what was requested. We are also asking the eTraceline site, when you are accessioning the patient, under patient file, under observations, if you can include the dosing schema for the patient from the request form, in addition to applying the 6-month expiration date, just as we currently do now with the annual and 6-month follow-up forms. Once the immune globulin has been issued, we would ask that the eTraceline sites fax, scan, or an email or fax to Blood Management Services the request for release. Blood Management Services has a data repository where they are collecting further information from these patients, such as if the dosing has changed, in addition to the indication for the patient. So they are keeping data on those patients as well as what we have in eTraceline. And again, if a lower dose was issued, if you can indicate on that cover sheet or in the email that you send to Blood Management Services with the request for release form, the dose that was issued. For outpatients, the process is primarily the same. The big difference here is that we're going to ask all of the requests that you receive go to the transfusion medicine service to be reviewed. So all of our outpatient requests will go to the TM physician, which is why we're asking the clinical areas to send us our all outpatient requests at least up to 7 days in advance. So the same process follows at the beginning as it would with the inpatient. And then with respect, once the request makes its way to the eTraceline hub site, again, we will ask that the blood bank scan the request form along with the prescriber document and send it to the same Bloody Doc email, this time using the subject line outpatient, IG request, and the date and time of the site. It's very important that we have the contact information for the hospital in case the TM physician does need to follow up and get further information before approving the request. The same process will follow if the request is denied. We will ask that the blood bank will complete the TM consult form and send that information off to the TM office as you would with the inpatients, which is very similar to the red cell utilization as well. And then the same once the immune globulin has been issued, if the issuing site can scan the request for release form and send that to blood management services, and again identify if a lower dose had been issued as opposed to what had been requested. On page 3 of the job aid is an appendix that shows you what a completed form should look like. We will already be doing an update to this. So again, we need to ensure that all the clerical information is captured, as well as the date, time, and a clinical indication. Information in here in order to calculate the height and weight. This IVIG dose is incorrect. That should be a 1 or a 2, definitely not 150. The dose schema, again, this is just an example of what can be written and what the request is for that day for that patient. Just an FYI, we've added a little bit of information at the bottom in the footer. We provide with an asterisk here under IVIG dose, under IVIG or SCIG, that the blood bank will issue the stock IVIG brand unless a patient has an adverse event, and at that point then the physician can write down the brand that the patient is to use. In addition, we've also just made a comment here with hematology to contact the adult or pediatric hematologist on call. Page 4 of the job aid, the second appendix, is a summary of all of the green clinical indications from the document, in addition to the typical grams per kilogram that would be given for that dose. So the blood banks do have a summary sheet here. You can print this page off and laminate it and keep it handy for your reference. Again, the dose calculator in Best Blood Manitoba, and there's a prescriber document, a label, and a letter for the ordering clinician. So these are all your new information that you need for the new process. So I do encourage you to take your time to go and review those and let me know if there's any questions. So to just reiterate some of the important notes with respect to the new process, the process is different between the inpatients and outpatients. All the documentation is the same. It's just we see inpatients have a greater sense of urgency. So what you would do in this situation is to ensure that a TM consult is submitted so the TM physician can look at the request and respond within a time frame appropriate for an inpatient. We do treat them as ASAP or urgent requests. The TM physician on call, we want to ensure that they have contact information. Here is an example of an email that was sent. So under the subject, again, you've got outpatient, IG request, the date, the time, and the facility. In the body of the email, they had the facility and a contact number of the facility. So the TM physicians know what number to call if they want to follow up with the blood bank regarding the request. Also a contact for the actual patient and a phone number, the name of the patient, and the dosing was reviewed. So this is helpful that we know that both the blood bank has reviewed it and the TM physician will review the dose as well. So for outpatients, because they're not as critical, we're asking that the clinical units try to send the request up to 7 days prior, and then the TM physician on call will review them. They are identifying Tuesdays and Fridays as days that they will review them and then get back to the blood bank whether they've been approved or not. At the request of the TM physician, a letter can be sent from the blood bank if the document does not contain the required information. So for e-traceline sites, we're asking that you continue to enter those 6-month expiry dates in addition to the dosing schema. The patients will no longer be exempt. So with the previous process, primary immunodeficiency or secondary immunodeficiency patients had been exempt from the process. This is no longer the case. When you are in e-traceline, please ensure that if you have come across a patient with PID or SID, that you remove the patient is exempt from follow-up as per clinical criteria, which we had been putting in the observations tab in e-traceline. And again, we want to capture when a lower dose is issued. So when you are faxing your request for release to blood management services, ensure to note when the calculated dose is lower than the requested dose, and you can enter that into their database. With respect to looking at the dosing for home program patients, we would consider the dose based on weight per cycle, with each cycle of treatment typically being about 4 weeks long. Another way to sort of think of it is the lifespan of the passive immune globulin is approximately 25 days. So that's why we look at about 4 weeks when we're looking at the dosing schema and the total dose. And that's what we'll compare to what is the outcome in the dosing calculator. So requests for ongoing therapy patients received before a 6-month expiry date. We are going to treat these patients as initial requests. So beginning December the 14th, every patient that comes in will be considered new. And I have a slide further along that kind of gives an example of this. So again, our current process right now for patients is they'll have an initial visit and they would get a request for release form and an initial form. And then if the patient needed to come back in 3 months, they would just need the request for release. And then at 6 months, the blood bank would get the request for release and the 6-month follow-up form. So how do these patients sort of fit in now that we're starting again in December the 14th? So I've got kind of an example here, and hopefully it makes sense. So a new process for patients who are currently on ongoing therapy. So for example, if we have patient Joe and his 6-month follow-up in e-trace line would be the 30th of March next year. But he'll be coming into the clinic the 20th of December for his next 3-month supply. And our new process goes into effect the 14th of December. So he's coming in for his 3-month supply after we've started our go live date. So when we see Joe on the 20th of December, we're going to consider him now a new or initial patient. The clinical units are aware that we will need the new version of the request for release in addition to a prescriber document. The request for release and prescriber document will then be sent to the TM physician for review. And then if it's approved, his new 6-month follow-up will be from the December 20th date, which means it would be the 20th of June will be his new 6-month follow-up. So to hopefully tie all this together and have it make sense, we've got case studies that we'll review. For case study number 2, we do the clerical check. All of our information is there. But here we find that there's no clinical indication. We need to send this form back to the clinical unit for follow-up or give them a call and find out what the indication is. For case study number 3, again, check your clerical information. Everything is contained. Here we have a clinical indication of myasthenia gravis. Again, this is a green indication, and it's an inpatient, so we can move down to look at the order. Here they're requesting 2 grams per kilogram, and the dosing schema is 30 grams per day for 5 days every 5 weeks. And they're asking for 30 grams to be issued today. So 30 grams over 5 days is 150 grams over 5 weeks. So 150 grams for 5 weeks. Calculated dose based on the information we're given would be 100 grams. So in this situation, we are going to issue the 100 grams. Because we're issuing a lower dose than what was requested, we will include the new label. We will put in what the adjusted dose issued was, the date, and the initials of the technologist. And this label will accompany the record of transfusion with the product to the clinical unit. Case study number 4. Again, we review all of the clerical. We've got a date and time required, a clinical indication of autoimmune blistering disease, and it is, again, a green indication. Here they're asking for 2 grams per kilogram, and they want 30 grams per day over 2 days for 4 weeks. And they're asking for 30 grams today. So over 2 days, that would be 60. And if we put this information into the dosing calculator, it comes out to 120 grams. Because they're requesting less than what the dose calculator calculates, we will issue exactly what they're asking for. We're good to go on that one. Case study number 5. So based on the location, we're going to know that this is a home program patient. They have an indication of primary immune deficiency, which is green, but they are considered an outpatient. And when we look at the dosing, they're looking for 12 grams per week for 12 months. And at this request, they're looking for 12 grams. So remember we talked about a total dose would be over 4 weeks. So in this case, we're going to take the 12 grams per week and multiply it by 4 weeks, giving a total dose of 48 grams. If we now take the patient's height, weight, and sex and put into the dose calculator, it's 55, which is higher than what they're requesting. So we will go ahead and issue the 48 grams for that patient. No change in dose required. And our last case study, again, based on the location, this is a home program patient. They have atopic dermatitis. We look, we see that that is actually a yellow indication. So the transfusion medicine physician, when he's reviewing the clinical indications, he's going to be looking at the prescriber document to see if it's warranted to continue on with the immune globulin treatment. The blood bank will look at the dosing. So here they're looking at 16 grams per week for 12 months. And again, we're going to look at 16 grams for 4 weeks to get a total dose, which would be 64. When we put that information into the dose calculator, it turns out to be 60 grams. So we are going to issue 15 grams as opposed to the 16. So that's all that we have with respect to the new process. Thank you so much for taking the time to go through this process. If you have any questions or concerns that you'd like answered, please feel free to reach out to anyone in the project team. If it's a clinical question, you can reach out to Dr. Masuka or Dr. Panamplam. If there's anything to do with the blood bank, with the lab related, you can reach out to myself. And thank you so much for taking the time to go through this online training session.